Good evening. My name is Dr. Upal Basuroy, and I'm the Vice President of Research at Longevity Foundation. And I am incredibly thrilled that I'm joined by my colleague, Dr. Amy Moore from Go-To Foundation for Lung Cancer and Dr. Nicolas Vabret. And we will be having a discussion on some of the immune aspects of COVID-19. With that, I'll hand it over to my colleague, Dr. Amy Moore.
Thanks, Upal. Yes, I'm Amy Moore. I'm the Director of Science and Research for the Go-To Foundation for Lung Cancer. And, I'm trained as a virologist and a cancer researcher, so I'm pleased to be able to participate in this discussion on a very timely topic of what the immune response to SARS-CoV-2 looks like and what does it mean when we talk about testing and antibody responses. And so, Dr. Vabret, thank you so much for being with us, and we'll let you introduce yourself to our audience.
Good evening, so thank you for having me. So my name is Nicolas Vabret. I'm an assistant professor in the Precision Immunology Institute at the Icahn School of Medicine at Mount Sinai. And so I'm essentially a researcher. I'm trained also as a virologist, and I work on the globally the innate immune response against viral infection.
Wonderful. So we're going to ask you a series of questions that we think will be timely for our audience, and we appreciate you working with us to address these. So the first is simply, what happens when someone is infected with the SARS-CoV-2 virus? And maybe you can talk to what the immune response looks like.
Yeah, so I mean, when someone is infected by a SARS-CoV-2 or any actually other virus, you have the body is going to produce an immune response, and generally we classify the immune response in two different steps. The first step that consists in the innate immune response, which is specifically the ability of all the cells of our body to detect that they are infected by the virus. So when the virus is going to penetrate the cells, we have like the proteins that will be able to detect the presence of the virus and to generate a signal which is going to alert the cells of the immune system that an infection is taking place, that the virus has penetrated the body. So this is the first step, the first wave, immediate wave, that is called the innate immune response. And the signal that is generated by this innate immune response is going to activate a second wave of immune response, which is called the adaptive immune response. And it's called adaptive because it's going to be specific to the virus that is going to infect you. So during the adaptive immune response, you have other cells of your immune system that's going to be alerted and activated, and that are going to produce weapons to fight the infections. And these weapons can be classified into two different classes of weapons. First, you're going to have the production of molecules like proteins, typically antibodies, which are small proteins, so molecules produced by the cell from the adaptive immune response, which is going to target the virus and is going to bind the virus to try to prevent its ability to infect new cells and to lead to its degradation, so its destruction. The second arm of the adaptive immune response is the production of a class of immune cells called T cells or cytotoxic T cells, which are specifically going to kill the cells that are infected by the virus to prevent the production of new viral particles.
Can you elaborate just a little bit on the timing of the innate versus the adaptive immune response and how quickly you can expect to see that innate response versus we know the adaptive one takes a little bit longer to come into effect?
Yeah, so the innate immune response is immediate. So whenever pathogens, so a virus like SARS-CoV-2 go inside your body, you're going to generate an innate immune response almost immediately, so within hours, basically. The adaptive immune response, because it requires the body to generate new weapons, so these new antibodies or new kind of cells, take much more time. So the objective of the innate immune response is going to contain the viral infections, during the time for the adaptive immune response, which are much more sophisticated tools and weapons against the virus, to take place. So the adaptive immune response generally is going to take between days and weeks to get to full capacity.
Right. Yes, I think that that's very helpful for our audience. And I know there's some confusion. They hear us throw around words like antibody. They may also hear us use the word antigen. Can you just briefly explain what an antigen is so that our audience can understand the difference between the two?
Yes, absolutely. So the antibodies is a molecule that is going to recognize the virus, going to bind the virus, and actually specifically the part of the virus that is going to be bound by the antibody is the antigen. So essentially an antigen is a part of the virus who is going to be targeted really to a cleft and a key, for example. So the antigen will be the viral part, and the antibody will be the immune system part.
Right. Very good. Okay, I think we can proceed to the next question.
And Amy, that's actually a great segue into the next question for Dr. Vabret, which is about how can we find out if someone is infected with the SARS-CoV-2 virus? And when I say is infected right now. So if someone gets infected today, how can we find out if that person is infected?
So, I mean, it's very straightforward. If you want to test whether someone is infected by the virus, you're going to look for a trace of the virus itself. So generally, we do a test that is called a PCR test, which is going to try to detect the viral RNA. So the RNA is a part of the virus, which is going to contain all its genetic information. So we have tests that can specifically look for traces of RNA that come from the virus, and to detect whether you have this RNA in your body, which is an indication that you have this virus. The second test that is being much less used, but that has been recently approved by the FDA, is to look at other parts of the virus, and generally you look at antigen, so similarly to what is recognized by the antibody. You're going to look at the presence of the viral a piece of the viral particle, so not the RNA, which is where the virus stores its genetic information, but you're going to look directly at the protein that is produced by the virus that form this viral particle that we often see in the picture.
Thank you, Dr. Vabret. And I think, Amy, that's going to be your next question then.
So we just talked about how you can tell if somebody is actively infected. How can we test if somebody has previously been infected with the SARS-CoV-2 virus?
So yeah, when you want to test whether someone was infected, and it's possible that this person recovered from the infection, so it's possible that it doesn't have any trace of the virus itself in the body. But if you want to test whether it was infected before, you can look at the immune responses. So we assume that if someone was infected, at some point he has produced immune responses, and you're going to look for these immune responses. So it was, for example, the antibody tests are about. So you're going to take some blood from a patient or from a people that you suspect that were infected by the virus, and you're going to look for the presence of these antibodies. And essentially, it's a test that is going to take, depending on the test, a few hours or a few days, and you're going to look at the presence of the antibody in the blood of the person.
Thank you. Next question.
So we talked a lot about antibodies and looking for antibodies. What exactly is an antibody test, Dr. Vabret? How do you do it?
So yeah, so what you do is that you, so when the immune system is producing antibodies, it's going to produce antibodies, and you're going to find it in the blood circulating in your blood system, because it's a way for the immune system to be able to detect the virus wherever it will be. So what we do is that we take blood from someone and we purify the serum, which is a liquid fraction of the blood, and we're going to look with a test which, without going into detail, is going to check whether you can detect this antibody in the blood.
And you mentioned earlier on about, PCR and RNA and, someone who's actively infected. Can an antibody test look for actively infected patients, or is it only used after a patient has gone through an infection?
So because of the dynamic of the immune response and the time that is required for the immune system to produce the antibody, you cannot detect antibodies in someone that would just have been infected. The virus need to have infected the body for certain times. So depending on the test, generally, what we consider is a good time start looking for the immune response, so to start looking for antibodies, is approximately 3 weeks after the onset of the symptoms. Because it's only at 3 weeks your body start to produce enough antibody that we can confidently test their presence or not. And so if you suspect being infected right now because you have symptoms, it's probably that the infection took place not a long time ago. So what you want to know, if you want to know if you are infected, you're going to look for the virus itself with a PCR test. But when generally we look at, we do perform antibody tests because we suspect a former infection, and we want to confirm that people have been infected a few weeks ago.
And how long does it take to get the results of the antibody test back, Dr. Vabret?
So there are many antibody tests on the market now. So they don't all work the same way. So depending on the test, I think some are going to give you a result very quickly, and some will need like more blood processing and more like sample processing, and could need a few days.
Thank you, Dr. Vabret.
So now the question on everybody's mind is regarding the accuracy of these tests. As states start to reopen and people go out and want to know, am I immune to the virus? Am I somehow protected? What do the antibody test results mean, and how accurate are they?
Yeah, so I think it's a very important question. So there is two things that is going to determine the accuracy of an antibody test. It's the ability of the test to detect what we call false positive and false negative. So false positive will be if the test says that you have antibody whereas you don't have any, and which might be a very problematic, because you don't want to say to someone, okay, we have detected antibody if it was not the case. The second thing that you test when you evaluate the accuracy of an antibody test is the rate of false negative, which is if the test failed to detect the presence of antibody in your system, whereas you have some. So there are many antibody tests on the market now, and they all have various false positive and false negative rates, different rates. And this is something that you need to take into account when you need to pick which antibody test you're going to take.
So I want to go into a little more detail about how we determine the accuracy of those tests. And is one test better than another? Patients want to know as they go out and look for the availability of these tests, how do they decide which one to get?
So the way, for example, the way you test for the specificity and the sensitivity, which is another way to say that you test for ability to detect false positive and false negative, is, for example, you have your test and people are going to screen a bank of like a sample that were collected before the epidemics. Okay, so we have like a bank of blood sample from a patient collected last year. So we know that last year there was no COVID-19. So all these samples should be negative. So you're going to test them, and you're going to see if the sample are if your test should never detect any sample. And so if it's going to detect a few samples that are going to turn positive, you're going to consider then your test detect percentage of false positive, for example. That's the way like the tests are evaluated. They are also evaluated against each other. So you have like the same sample that are going to be tested by the different tests, and you're going to see which one are the best.
Does the timing of the tests matter? So, you know, we talked about kind of the innate versus adaptive immune response, and that the adaptive immune response often takes a little bit longer to come into play and for those antibodies to be generated. Does it matter when in the course of infection and recovery a patient goes and gets an antibody test?
No, yeah, absolutely. So what the physicians advise today is to wait at least 3 weeks after the onset of your symptom, because earlier you might not detect the production of antibody, even if your body is in the process of producing them. You really want to make sure that you are at the peak of the ability of your immune system to produce antibody, to test them at this point, to really reduce the chances of having a false negative.
So we know that SARS-CoV-2 belongs to a family of coronaviruses, which includes 4 kind of naturally circulating ones that cause more or less a common cold. And then there was the original SARS and then MERS. Is it possible that a prior infection with one of those other coronaviruses could give you a positive test on this antibody test?
Yeah, so I mean, on this question, I don't think that we have a definite answer. I think there are reports saying that indeed the antibody that you would have produced against these common cold viruses, these other coronaviruses that circulate in the population and cause like mild disease. So there are reports saying that you could have some cross-reactivity. So what you would think would be an antibody against COVID-19 would actually be an antibody against one of these other coronaviruses. Other reports say that there is absolutely no cross-reactivity. So I think that the jury is still out, and it's probably very dependent on the kind of antibody test that you use. Some are more specific in this sense than others.
Upal, I know we had some additional thoughts and questions on how we interpret these antibody tests, especially when it comes to issues like convalescent plasma and some other considerations. And I'll let you kind of take that piece of it.
Yeah, so I think that's the most important question here is, what do you do? What do you make of it if you have a test that say, okay, you have antibodies? I think it's really important to understand that we don't have all the answer yet. So producing antibodies is probably a good sign, saying that you have some level of protection against possible reinfections. But we don't know yet what level of antibodies you need. We are not completely convinced that antibodies will be enough to ensure that you will be protected against reinfections. And we are, I mean, what people need to understand here is that the epidemic is very recent. So we have only a few weeks, a few months of analysis and follow-up of patients to be able to generate data on, and we cannot ensure at all that the fact that you would have a positive antibody test, like in addition to all the problem of specificity and sensitivity of the test, even if we were trusting 100% the test themselves, we cannot yet conclude that it means that you are immune to reinfections and by SARS-CoV-2.
That's actually a great segue to my follow-up question, Dr. Vabret, which is, if I have antibodies as a patient, and we get this question a lot from, the caregivers, people who look after patients, we get a lot of questions from them saying, oh, I have antibodies today. does that mean I will stop infecting people around me? So if I have antibodies, am I not infectious anymore?
Yeah, so it's also a question for on which we cannot have definite answer yet. We know that people who recover from infection, the large majority produce antibodies.
Mm-hmm.
But when you test them, a few recent studies actually from Mount Sinai Hospital show that even if you had antibodies but you recover from infection, you can still detect some viral part in your body. So we don't know yet if this virus is alive, if it's complete, if it's able to infect new person. We know that we can detect it, but we don't know if it's an infectious virus and if there is a risk for someone who recovered and have antibody to transmit the virus. It's something that we haven't a definite answer on, unfortunately, and we cannot really give any advice except being extremely cautious.
And what about, the severity of cases? We've heard that some people get a very bad case of COVID, some people have a mild case of COVID. Does the level of antibody response differ between the mild and the severe? Do they have the same amount of antibodies, or is it different?
Once again, something on which the few studies that we have are not completely according with each other. But it seems that the level of antibodies, so what we call the antibody titers, it's like the level of antibody that you generate, is not really correlated to either the severity of infections or the length of the symptom that you have. So people are working on it to try to understand exactly what's happening and what determine whether you're going to induce a very strong antibody response or low antibody response, but it's another thing for which we don't have a definite answer.
That's very helpful to know, Dr. Vabret. Then in terms of, so Amy talked about antibody tests and questions that we get from some of our community members who've already got tested. Some tests show IgM and IgG. Some tests only show IgG. So can you tell us a little bit about what IgG is, what IgM is, what IgA is?
Yeah, so IgG, IgM, IgA are different classes of antibodies. So without going into details, they all have like different functions, different kinetics, length of how long they're going to stay in the half-life, how long they're going to stay in the body, in which part of the body they're going to circulate to survey any infection. But they are just different classes of antibody, and we like to test the different classes as, I guess, a better to have a better sensitivity to make sure that what we detect is actually an antibody response.
So with a test which only looks at IgG versus a test which looks at IgG and IgM, is the IgG-IgM test better than the one which only looks at IgG?
At this point, it really depends on the test and the accuracy of each test. But as a rule of thumb, like testing two different kinds of antibody is probably better than only one.
Okay. And now for the big question, which all of us are interested in: how long do the antibodies last?
Yes, so so at this point, as you can imagine, we don't know because the infection started the epidemic started at the beginning of the year. So we don't know. We do have some clues because we can get some information from other coronaviruses. So as you were mentioning, there are other coronaviruses that infect the human and cause a common cold and circulate in human population. So we have data on how long the antibody stay in this infection, but we also have data on other coronaviruses that looks more like SARS-CoV-2, which were the initial SARS and the MERS coronaviruses. So both were viruses that cause outbreak in 2003 for SARS and in 2012 for MERS. And they cause like pathology that are more similar to the one that we observe in COVID-19, much closer to what we observe in COVID-19 compared to like the common cold viruses. And on these viruses, we look at we know approximately how long the antibody response was, and it for MERS, for example, we knew that it could stay more than a year, at least 2 to 3 years, and it was after it waned progressively. So it's absolutely not an insurance of that the antibodies against SARS-CoV-2 are going to behave similarly. It's merely some kind of indication that provide a basis for researchers to study these antibodies and to compare. We can hope that we will see antibody response in the case of COVID-19 that's going to last more than 1 year, but we can't be sure yet.
Thank you, Dr. Vabret. Amy, do you have additional questions? I'm going to turn it over to the virologist in our team.
I'm going a little off script here, but the virologist in me is just thinking about the implications of the immune response as it relates to vaccines. And, you know, if you had to predict, do you think, you know, a one-time vaccination will be sufficient, or do you foresee that we may be in a situation where we have to get annual or every other year vaccinations? And I guess it kind of depends on the modality of the vaccination as well, but
yeah. So what I like to say is that when you design a vaccine, you aim at generating an immune response that is going to be better than the one that is induced by natural infection, right? So ideally, you would like to design a vaccine that is going to induce an immunity for life. Some vaccines do. We only have like one vaccine injection when we are kids, and after we are immune for life. There is one thing that is a source of hope in the case of SARS-CoV-2 is that if you compare SARS-CoV-2 to other RNA viruses like HIV or polio or even influenza, SARS-CoV-2 on all the coronaviruses have this particularity that they are relatively stable. So we know that polioviruses, for example, mutate a lot. HIV is one of the reasons why we are struggling so much to produce a vaccine. Influenza, every year we are infected by a different strain of influenza. And so we know that the vaccine that we have can only protect us for the year. In the case of SARS-CoV-2, data so far show that it's relatively stable, and that we can hope, for example, that a vaccine will be able to protect for the moment against all the isolate of SARS-CoV-2 that circulate in the world, because they are relatively similar to each other. And but it's pure. It's just like a speculation, and we definitely need to look at, like, survey the different vaccine candidates that are being produced right now. Look at the kind of immune response that they generate. Is the immune response going to be protective? Is the protection, if they are protective, how long the protection is going to last? All are questions that researchers are working hard on right now, and hopefully we will have answer as soon as possible.
One last question on just kind of general immune responses is we know that, you know, the elderly population has been particularly hard hit. We also know that the immune system is maybe not as robust in elderly patients. Can you speak a little bit to that and the added challenge of how we address that when, you know, we have immune exhaustion or senescence and other kind of dampening of the immune response in older patients?
Yeah, so I mean, in terms of vaccination, I think it's a very important point, because ideally you will want to have vaccines that will work particularly well in elderly population, because they are the ones that are with higher risk. So it's really the population that you want to protect first. And as you said, like, the immune system the aging of the immune system in older people make it more challenging to elicit like a good, like strong immune response. So this is one of the challenges of the vaccination for sure. In terms of linking the aging of the immune system to the higher pathogenicity of the virus in older individual, I mean, at this point, it's really speculation. It's very tempting to consider one of the reasons why the older people will have higher severity of disease because their immune system is not as efficient as the younger people. It's one of the main target of immune research right now, but this is for the moment nothing more than a theory, even if it's very interesting and straightforward theory.
Yeah. So, I think, the ultimate question is people want to know, how do I get tested? So Upal, do you want to wrap up that conversation?
Yep.
Yeah,
actually,
so,
that's a perfect ending to our discussion. How should people get tested?
Yeah, so, I mean, there's two things. The question is, should I get tested? I think that so far, since we don't really know the link between production of antibody and protection, or we are not really completely sure that production of antibodies means protection against reinfections. There is a real question whether is it worth it to get tested? Because if you have the result of the test and you don't know what to do with it, or like what you conclude on that, it's one of the first questions. Today we can say yes, probably having antibodies is probably a good sign of a small level of protection. I mean, I feel confident to say that today, but in no way it's an insurance that you are protected. So I think that people need to be completely, once again, I really want to insist on that, people need to be aware of that before getting tested. The second thing is, I want to get tested, but there are so many tests available. I don't know which one to test and to take, and I don't know how to compare them, and I don't know. I don't understand what's exactly this means, this accuracy, specificity, sensitivity. So the best way here, but I would say in this case, is that if you have access to, if you can see your physician, you go see your physician and you ask, he can order a test for you, and it will exactly explain to you the parameter and the accuracy of the test and what you can conclude on this. I mean, I know that in New York, you can just like go in a CTMD, I think, and just ask for a test and pay out of pocket. I think that if you really want to get the most out of the test, is probably better to go through your physician, who will order a test that you trust, and that will be able to advise you on the result that you will get.
Dr. Vabret, since you mentioned New York, and I happen to actually live in New York City, do you think that it's more sensible to get tested in New York City because of the infections around you than, say, if you're living in somewhere in the Midwest where the cases of COVID are much less?
I think it really depends on the kind of test that you have access in New York and in the Midwest. If it's the same test, I don't see the reason why you should get tested more in New York than in the Midwest. I think at this point the epidemics is really everywhere, and of course the density of the population in New York and the fact that it was the epicenter of the epidemic means that there are much more. The density of infected people is much higher, but it would not be a reason for why you should be less careful because you live in the Midwest, unfortunately for the moment.
Perfect. I think that's a great conclusion to our discussion. Thank you so much, Dr. Vabret, for joining us.
Thank you for.
Thank you so much for your work and your time today. It's going to be hugely meaningful to our community.
Thank you.
Thanks.